Welcome, and thank you for joining us this afternoon for today's Lunch and Learn with the Doctors on Pancreatic Cancer. My name is Jennifer Heiss, and I'm a reference librarian at Plainfield Public Library. Today's program is brought to you by Regional Cancer Care Associate, Central Jersey Division, Princeton Radiation and Oncology, and the Plainfield Public Library's participation in the Healthy Plainfield initiative to promote community health and wellness. Our speakers today are Alexander Iskovich, MD, and Richard Schuman, MD, Fellow of the American College of Physicians. Please be aware that this talk is being recorded. Please keep your microphones muted and your webcams off for privacy purposes. The recording will be available on the library's YouTube channel as soon as we can get it up after there. And the URL is on your screen. If you have any questions, please type them into the chat box. The doctors will answer questions at the end of the talk. The doctors presenting will not be able to offer personal medical advice to attendees during this program. And without further ado, I'll turn things over to the doctors.
Okay, so let's get to the slides. And the next slide after that. And one more. So one more slide before we go.
Yep. Okay.
So
whoops, went backwards.
Pancreatic cancer has been in the news for the past several months. There have been some high-profile people who've had this condition, died recently, and in the style of Jeopardy! And in honor of Alex Trebek, I thought I'd start in this fashion. So next slide. And Jeopardy, of course, the answer is cancer of the pancreas. Next slide. And next slide. So the question is, what did the following people have in common? Next slide. Okay, Alex Trebek passed recently, but a very public about his fight with cancer of the pancreas. We know he was diagnosed in stage 4 and had chemotherapy. He seemed to respond, and more recently was on other treatments and did not. So next slide. We have also this woman who recognizes Ruth Bader Ginsburg, whose untimely death led to a big fight in the government. Next slide. John Lewis. John Lewis is a congressman from Georgia who passed in July, civil rights leader, very respected. And of course, what's going on in Georgia now may have something to do with his legacy as well, the influence. Next slide. Not only politicians, but we have actor, Patrick Swayze. Next slide. Singer, Aretha Franklin, who died of pancreatic cancer. Next slide. And Pavarotti, who is another singer. It's not just singers and politicians. Next slide. We have business people, actually sports people. I don't know if anybody recognizes this gentleman, one of the greatest right-handed pitchers of all time, Bob Gibson, died of pancreatic cancer. Next slide. And Steve Jobs. Steve Jobs had a different kind of pancreatic cancer that will be discussed. There's 2 different types, and he had a different kind called neuroendocrine, rare kind. Next slide. So it doesn't just fit to hit celebrities and sports figures and politicians, but also members of our family. This happens to be my grandmother, who died of pancreatic cancer several decades ago. So it obviously it's in people's families as well, and of concern. Let's go to the next slide. So why is pancreatic cancer important? Here's some statistics that are, to me, a bit surprising. It shows that there were estimated for American Cancer Society 57,000 new cases in the United States this year. I don't know if it's different because of COVID, but that was what was speculated at the beginning of the year. Of 57,000 new cases, there were 47,000 deaths in the United States this year. Represents 3% of all cancers, but 7% of all cancer deaths, and it's increasing. In 2015, 14, it was a number 4 cause of cancer deaths in the United States. Last year, it was a number 3 cause of cancer deaths in the United States, and now, and going forward, it will be the second highest cause of cancer deaths after lung in the United States. Next slide. Going over further statistics shows you that although it's by far not the most common type of cancer, breast cancer, 260,000 new cases, of which there are only 41,000 deaths. They're doing a lot better. Prostate cancer, colorectal cancer, you see that the number of new cases are much higher than pancreatic cancer, but the deaths due to pancreatic cancer as a percentage of the patients who are diagnosed is very high. And maybe we'll see why that is as we go further down. Next slide. So the question is, why is it lagging in terms of treatment, and why is it so many deaths as a percentage of diagnosis compared to other cancers? Well, first, it tends to be a cancer that is late in being diagnosed. So if you compare to other cancers such as breast cancer, colon cancer, prostate, and lung, there's better screening in detecting other cancers. Breast cancer, we do the mammograms. Colon cancer, colonoscopy. Prostate cancer, a lot of men are getting screened with PSA tests. And lung cancer, even now, we're starting to screen patients with low-dose CT scans. There is some screening for prostate cancer, but we'll talk more about it. It's harder to diagnose, and the screening methods are not quite as good as in other malignancies. Next slide. In addition, the symptoms tend to be later and very vague. And as a result, the diagnosis is usually in the more advanced stages. And even if it's diagnosed in an advanced stage compared to other malignancies, the current chemotherapy options are non-curative and limited. Even radiation therapy, given in other diseases, is curative and not so much or even at all in pancreatic cancer. Next slide. So here's some statistics, which I'll go over in a slightly different way later. But if you discover colon cancer in a local situation, in other words, it's just limited to the colon cancer, to the pancreas, their survival for 5 years is 25%. But we only find 9% of the patients with pancreatic cancer at the local, well, I'll come back a little, at that stage. Whereas regional means that there's lymph nodes involved. We find a few more like that. They may be resectable, and the survival is 10%, meaning 90% of those patients will die, even though it's only spread into the lymph nodes. And distant spread is how we find majority of patients. It's already beyond the pancreas, and the survivability is quite dismal for 5 years, only 2%. Next slide. We also see that the age distribution is non-favorable, is that the median age of diagnosis is 71, and actually the 75 to 84 has the most number. It's not a disease of young people. In patients who are less than 35 years old, it's a very small fraction of the number of patients who come down with this disease. Next slide. So we want to know about where the pancreas is and what does it do. And here's a happy pancreas. As you can see, he's in good spirits. His host has been very kind to him. The person who has this pancreas is not a smoker. He's not doesn't overindulge in alcohol. He's not terribly obese. He's got a nice, healthy pancreas, eats well, and the pancreas will take care of you. And you look to see the normal pancreas is about 6 inches long, about 1.5 inches wide, and it sits in the upper middle abdomen between the small bowel and the spleen. Next slide. So there it is, that yellow thing that's labeled pancreas. And we'll point this out again, I think multiple times. The gallbladder is a green bulb at the end, under the liver, and the ducts come through the pancreas and out into the small bowel, and they aid in digestion. Next slide. And so when we talk about the pancreas in terms of where the tumors occur, it's basically into 3 regions: the head of the pancreas, the body and the tail, and you see the duct, which is where the pancreatic juices flow. go through the middle of it, and they come out from the tail to the body, to the head. Now, some people will actually divide this into 5 sections. As in a human being, between the body and the head is our neck. So the neck is in between. And that little part that hangs out in the bottom is sometimes called the uncinate process. Next slide. So next slide. Okay, so the pancreas is really 2 organs. It is an endocrine gland and an exocrine gland. Exocrine means it has enzymes that help in digestion, and those help digest protein, which is trypsin, fats, which is lipase, and carbohydrate, which is amylase. So it breaks down the food that we eat into smaller pieces so that our body can absorb them. And that's the big, major part of the pancreatic gland. But it also has these little things that are called islets of Langerhans. And these little glands, and there's multiple ones, secrete hormones, and that's called the endocrine portion of the gland. And there's at least 5 different types of groups of cells. Insulin is in the beta cells, and insulin, of course, if the pancreas is destroyed by tumor or something or some other process, or it's taken out, leads to a person being diabetic. But there are also other types of hormone being secreted, and each of those, if affected by a tumor, could be increased in secretion and cause symptoms. For instance, glucagon, which is kind of opposite insulin, polypeptide, which helps in digestion. So diseases can cause, with secretions of these things, can cause diarrhea or other symptoms. Might be early symptoms, but you don't get that as much with the endocrine gland. Next slide. So here's a cross section of the pancreas cut. Now, so the other thing you notice about the pancreas is kind of bumpy on the outside. And so if a tumor gets in the outside portion of it, you wouldn't notice one other bump. Another reason why it might be diagnosed late. So these little blue things, which they're not blue in nature, are the little islets of Langerhans that are there secreting the hormone into the bloodstream, and the enzymes that help in digestion go out through that little green looking duct into the small bowel. Next slide. So this is my thoughts is that telling you about the islets of Langerhans, that this Dr. Langerhans, who's a German pathologist, described them in the late 1800s, and unfortunately, it wasn't Dr. Gilligan who had discovered this, or it'd be Gilligan's islets. All right, next slide. And this is what it looks like under a microscope. These little round things. And this is a stained specimen. I don't know what they look like in real life when you section it. You'd have to ask Dr. Iskovich. He's seen a lot more pancreases in real life than me. Next slide. Okay, so we talked about the neuroendocrine tumors, and these tumors really are rare. They're only 10% of all pancreatic cancers. And next slide. And again, just to reiterate, this man died of this kind of tumor of the endocrine system, not of the exocrine system. Next slide. The exocrine system is 90% of all pancreatic cancers. They do tend to occur in the head part, the pinkish area, as opposed to the tail. And next slide. In fact, it says that 60 to 70% of the tumors occur in the head, 5 to 10% in the body, and 10 to 15% in the tail. Now, the average size of the carcinoma in the head of the tail, head of the pancreas, is only 1 inch in size compared to 2 to 3 inches in the body or tail. And why is that? Let's go back one. If you look at that picture, you see that that tumor is stuck in a duct, and it's small. The ducts tend to be in that side, and that presents with earlier symptoms because it can sometimes block the duct and give a patient turn a yellow color, and that's a presenting symptom that may be earlier occurring in the patients who have the tumor in the head of the pancreas as opposed to the tail. On the tail of the pancreas, the symptoms tend to be later, and therefore they're found later. Next slide. So staging, and you're going to hear this again. I think Dr. Itsu is going to tell us about this, where we talk about the staging, which is kind of directs how our treatment is going to be given. The staging, if the tumor is, next slide, if the tumor is localized and small, it'll be stage 1. If it's localized but going to other organs, stage 2. Next slide. And it can divide it to A and B based upon how big it is. And stage 2, A and B, based upon some lymph nodes that are involved. Next slide. Stage 3, where all of a sudden now it's gotten into some vital areas that become unresectable, such as into blood vessels. Next slide. Stage 4, when it is spread into distant areas, such as the liver or the lungs, bones, distal lymph nodes, ones that are not near the pancreas and cannot be resected, even the brain. Next slide. So again, the statistics, now that we've done staging, shows, again, the survivability of 5 years with stage 1 and stage 2, which are theoretically possibly resected, are 20% and 10% respectively. Stage 3 and stage 4, the 5-year survival is very poor. But the incidence, most of these patients are discovered in stage 4. Next slide. Again, stage 1, there's another picture to show us when the tumor is in the head of the pancreas, where it could block that greenish duct going into the small intestine and back up into the liver and cause the yellow color. Next slide. So the diagnosis is based upon, most of the time, based upon a person complaining of something. And the complaints, if it's in that head of the pancreas and it's causing blockage, can make a person turn yellow. It's called jaundice. Makes the urine dark. And because it's blocking the bile from the liver going into the bowel, it causes a light-colored stool. And because some of the symptoms are decreased appetite, you're going to get weight loss. Fatigue is probably the most common side effect. And because the pancreas is right in the middle of the abdomen, halfway into the back, and can cause back pain or abdominal pain, fullness after eating. But again, these are all late signs. Worsening of diabetes will be a late sign because you're replacing a lot of the pancreas with the tumor. Next slide. Now here's a longer list of the symptoms. And again, asthenia, which is a feeling of malaise or fatigue, and weight loss, very high. Anorexia, people complain of this. You have to think about pancreatic cancer, and of course that's when the scans are done. Maybe half the patients have the jaundice, which may be an indication of it being in the head of the pancreas and blocking a duct. But you see 50% of patients have back pain, and about 70% of patients have abdominal pain because of the location. Unusual one is thrombophlebitis. Sometimes a patient will present with a blood clot in their leg, and that will lead to somebody doing a scan to see why, and we'll find it, but that's pretty uncommon. Late signs such as fluid, which is ascites, and that's pretty far along, and usually there are symptoms before then. Next slide. Okay, so now that we've been diagnosing it, we have to talk about treatment, and that's where and why I invited Alex to be with us today, and he invited me, because it involves a team approach to treatment. You have a surgeon, radiation oncologist, and a medical oncologist working together to try to design this, but it's a team including more, such as nurses, physical therapy, dietary, pathologist has to make the diagnosis, radiologist helps us, and sometimes a hospice, or often hospice, because it's such a frequently fatal disease, helps us. Next slide. So At this point, we're talking about our surgeons and our one method in which this can be treated, in fact, the only method where it can be cured. So, Alex, why don't you take it from here?
Okay. Good afternoon, everybody. So I will be discussing the surgical approach to pancreatic cancer. Like Dr. Schuman discussed, surgery is a small portion of the management of pancreatic cancer because unfortunately we do get to very few patients that are operative candidates. Next slide. Can I see the next slide, please? All right, so I included some folks Dr. Schuman had already mentioned. Next slide. So my goals for this presentation are to understand what makes a patient a surgical candidate, understand the role of imaging, which is usually a good CAT scan, understand how pancreatic cancer is staged, and then we talk a little bit about the surgery itself and the role of screening in pancreatic cancer. Next slide. So the first thing to diagnosing pancreatic cancer after a doctor figures out that this is a likely diagnosis is a CT scan. A CT scan is a device that uses radiation to take a look at inside the body of a patient and evaluate multiple organs, a part of which is the pancreas. Next slide. The CAT scan has several ways that it can take pictures of you. So it can look at you in the axial view, which is across, in the coronal view, which is head to feet, and in the sagittal view, which is back and front. Next slide. So this is the typical anatomy of the pancreas, which Dr. Schuman had mentioned several times. And understanding this anatomy is very important because the CAT scan will reveal things along this anatomy. Now, many people have variations in anatomy, but there is a typical anatomy that we do see probably 60 to 70% of the time. Next slide. A typical pancreatic cancer, is found basically anywhere, but it's very commonly found in the head of the pancreas. And the first question that a surgeon will ask is, does the cancer involve the vessels? Next slide. So if you take a look here, this is a CAT scan, and in the coronal plane, and the T represents the tumor, and the PV represents the portal vein, which is one of the big blood vessels that runs right behind the pancreas. And one of the things that I will be showing you is how we evaluate whether somebody is a surgical candidate. In this patient specifically, the tumor T is away from the portal vein, and you can see that there is a little bright area between the portal vein and the tumor that we call a fat pad, and that tells us that the tumor is actually away from the portal vein, which is a good sign. Next slide. So what are the things that we look for in order to be able to tell whether somebody's pancreatic cancer can be removed? The first is we look for the arteries that are in the area, and we evaluate whether or not those arteries are involved with the cancer. Second thing that we do is we look for the veins in the area, and we evaluate those. In order to be able to tell whether the tumor involves each, we do something called a triple phase CT. That CAT scan, what it does is it looks at the arteries initially by injecting dye and then taking a picture when the dye fills the arteries, and then it waits a little bit and takes a second picture when that dye fills the veins. And by looking at both set of pictures and evaluating where the tumor is, that's how we know whether the tumor involves the vessels. Next slide. So there are really four types of pancreatic cancer from a surgical perspective. There's something called resectable pancreatic cancer, which means I can take it out right away. There's something called borderline resectable pancreatic cancer, which is the tumor involves the vessels, but I think I can still get it out by removing either part of the vessel or giving some chemotherapy to shrink it so that it can be removed later. There's something called locally advanced pancreatic cancer, where the tumor involves so much of the local area that it is not removable surgically. And then, of course, there's metastatic pancreatic cancer, which is when the tumor has spread outside of the area of the pancreas. Next slide. I'm going to show you some CAT scans regarding each of these, but just to give you some ideas. So initially, localized pancreatic cancer, we find in about 8% of patients. So what that basically means is that we can remove the tumor right away only in about 8% of people. In 15%, it's borderline resectable. It's locally advanced in about 26, and the rest of it is metastatic. And the reason that, as Dr. Schuman had mentioned, that we have such poor survival in pancreatic cancer is that the bulk of patients fall into either the unresectable category or into the metastatic category. Next slide. So there are some technical things that are important about the arterial and venous anatomy for resection, but the bottom line is that the tumor for an immediately resectable pancreatic cancer cannot touch any of the arteries. If it touches less than 180 degrees of the vein, it is still considered a resectable pancreatic cancer, although now most folks would still call that a borderline resectable. Next slide. So here you see a resectable pancreatic cancer, a tumor that is very far away from the actual blood vessel, and it can be easily removed based on the fact that there is a plane in between the two of them. And as I show you the next slides, you will see that that starts to disappear. In fact, the way that we're looking at this patient's imaging is that the feet are behind me and the patient's face is in front of me, and this is taking a direct cut through them. And so, next slide. So the borderline resectable pancreatic cancers, you generally do not have, any. You do have some solid tumor contact with the arteries, but it is less than 180 degrees. Specifically, the SMA, which is a major, which is one of the major blood supplies of the bowel. Some of these things are fairly technical, but what I would like to show you is what the CAT scans look like. Next slide. So what a borderline resectable tumor basically means is exactly what this picture shows. If you're imagining the blood vessel that runs right next to the pancreas, if it's less than 180 degrees of surrounding tissue, that's what it looks like on the left. And then on the right, you have greater than 180 degrees of surrounding tissue. Next slide. In this case, as you see in this case, you see the tumor, and then now you see where the SMA is and the SMV, and you can see that the pancreas is kind of, the pancreatic tumor is kind of around that vessel. And that's what we call a borderline resectable tumor. And generally, these people go to chemotherapy before they have surgery. Now, I will talk about that in a minute. Next slide. So the borderline resectable pancreatic cancers, again, they have solid tumor contact with the SMV or the portal vein greater than 180 degrees. So really, what really matters when I'm looking at these pictures to determine if somebody has a resectable tumor or not is what percentage of that blood vessel is spared. Because if I can remove a portion of that blood vessel while keeping that tumor all in one piece, then I need a certain amount of wall to be able to reconstruct the rest of it. That's why we have that 180-degree designation. Next slide. And again, same thing goes for the arteries. Here there are some, additional details that certain people have, venous anatomy that is a little bit different than others. Some folks also have tumors that are very low, and some people have tumors that are very high. So what that basically means is that these blood vessels don't exactly touch the pancreas in the same way in every individual. And so you really have to tailor the approach to the individual patient. Next slide. Locally advanced pancreatic cancer is just like you see here, there's a tumor all around the area of the head of the pancreas. And in this situation, there's really, it's very difficult to remove anything all in one piece because the tumor has already spread beyond the origins of where it's safe to remove. Next slide. Finally, if you take a look at the liver in this patient, which is on the left, you could see metastatic disease. That's a signal that you really should not be removing the lesion. Next slide. So how do we, once we get the CAT scan and we see that there's a tumor, what's the next step? Well, usually what I do is, or myself or Dr. Schuman, is we refer the patient out for something called endoscopic ultrasound. Endoscopic ultrasound is a type of imaging modality that uses an endoscope, which is like you would have an endoscopy to take a look inside your stomach, with one particular advantage. The scope here has a little ultrasound machine at the very tip of it. And it also has a biopsy channel. So you're able to take little pieces of tumor. And so what they're able to do is they find the pancreas, usually either through the stomach or through the duodenum, and they pass a needle into the tumor and take a little piece of it under ultrasound guidance. And this is what gets us our tissue to confirm the diagnosis. Next slide. So EUS is the modality of choice. If you have locally advanced disease, it's used to confirm the diagnosis and guide chemotherapy. In resectable disease, biopsy is often not necessary if proceeding directly to surgery. So if the tumor looks completely like it does not touch the vessels, the radiologist is sure it's a tumor, and the patient has the typical signs and symptoms, we at times take the patient to surgery without a biopsy. This happens very rarely, about 8% of the time, but we do this from time to time, and it prevents a person from getting an additional procedure in this particular acute circumstance. In addition, we oftentimes need to biopsy the pancreas because sometimes we can be surprised. In certain patients, the biopsies can come back as other rarer things like renal cell carcinoma and melanoma, which, on occasion we will see. Next slide. So, briefly, Dr. Schuman discussed all of the staging with you. This is just a chart about the staging. Really, the 1A and 1B really get separated by tumor size. And then the two, stage 2 is really, we're talking about, the tumor being beyond the pancreas with some lymph node involvement. And then the stage 3s already are involving the blood vessels, and stage 4 is metastatic. Next slide. So the question is, how do I decide whether or not somebody's a surgical candidate? Well, we look at 3 main variables. First, we have to be sure that the person does not have metastatic disease, and we know that based upon the patient's CAT scans. This is very important because if the patient has metastatic disease, the operation will not help them, even if they have a locally resectable tumor. The second thing is we look at something called performance status. It means, will the patient be able to take the operation from a physiological perspective? Is their heart strong enough? Are their lungs good enough? Are they going to be able to tolerate 4 to 6 hours of anesthesia? And that's very important, and falls into a critical aspect of the decision making. And then finally, we look at whether the patient is resectable or borderline resectable. And the difference between these two is that if the person is a surgical candidate, is whether or not we will give chemotherapy before or after the surgery. And if the patient falls into the borderline resectable category, almost always we will give chemotherapy before we remove the tumor. If the patient does not have a stable cancer in a borderline resectable case, that means that the surgery would not have benefited them. That is the rationale for giving them chemotherapy up front. In resectable pancreatic cancers, we often will operate before chemotherapy. However, this practice is changing, and I believe that in the next 5 years, preoperative chemotherapy will become the standard across the board, and all pancreatic cancers will be getting chemotherapy up front. Next slide. So one of the common markers that people will order is something called a CA19-9 level. It's oftentimes associated with pancreatic cancer. However, it's found in both benign and malignant conditions. And one of the things that most people don't realize is that if somebody's main duct of the liver is blocked, the CA19-9 will be elevated. This oftentimes gives people false positives regarding pancreatic cancer. And so I caution anybody with a CA19-9 level to really think twice. It really has to be in the correct context to be interpreted correctly. There are also certain people that cannot produce CA19-9, even though we use it as a way to track pancreatic cancer. So it is a good marker in the right patient. Next slide. So we talk about management, like we said, resectable pancreatic cancer, surgery plus adjuvant or postoperative chemotherapy. If it's a borderline resectable pancreatic cancer, we give preoperative chemotherapy plus or minus radiation, and then assessment. Locally advanced pancreatic cancer is really chemotherapy plus or minus radiation, and metastatic pancreatic cancer is also generally just chemotherapy. Next slide. All right. One of the things that we sometimes do is we put a camera into the belly to determine whether or not a full operation is necessary. So in patients who are high risk borderline resectable, before I do a full-blown operation, I generally put a camera into the belly to make sure that there isn't disease that I'm missing. Because if we do find disease that we're missing, then I save them from getting a major operation that will not benefit them. Also, if the CA19-9 levels in the appropriate setting are very high, then there is a clinical suspicion for metastatic disease, and I will then proceed with a laparoscopy. Next slide. So one of the things that we often come across in the hospital when patients come in with pancreatic cancer is they have obstructive jaundice. What that means is that the main duct of their liver has been blocked. So what obstructive jaundice is a complicated situation, because the question becomes if the obstructive jaundice, first of all, can be caused by many things, but when it is caused by pancreatic cancer, placement of stents, if you're intending to go to surgery initially, can increase the risk of infection. So a pancreatic cancer specialist should really see that patient and evaluate them for resection prior to any instrumentation. The other important part is it takes about 3 weeks for your liver function test to become normal after obstructive jaundice. So we oftentimes have to wait a little bit before we can take somebody to the operating room when we do decompress their biliary tree. Next slide. So a little bit about the actual technical portions of surgery. So there are really two types of procedures that are performed for pancreatic cancer, and they really depend on where the tumor is located. If the tumor is located to the left of the major blood vessels, the SMV and the SMA, then generally we do something called a distal pancreatectomy, which means we remove the lateral part of the pancreas. If, however, the tumor is located to the right of those vessels, then we have to remove the entire head of the pancreas, which is a very large operation, the Whipple procedure, and it is one of the largest procedures performed in the abdomen. It involves removing all of that whole ductal system that you saw in that anatomy, and all of that needs to be reconstructed. Next slide. Next slide, please. So the Whipple procedure basically involves removing everything that you see on the left and disconnecting it, and then recreating it as you see on the right. It's a very involved procedure that's difficult even for young surgeons to understand. And it's basically involves removing the bile duct, removing a portion of the duodenum, and removing the head of the pancreas, all involved with the tumor. Next slide. This is just some further operative descriptions of what we discussed. Next slide. So when we remove everything, they need to be reconstructed. And what we're left with is, once the pancreas has been cut, the bile duct has been cut, and the stomach has been cut, you have to make connections for all of those items. And so as a result, we have to make a connection between the intestine and the bile duct, the intestine and the pancreatic duct, and the intestine and the stomach. Next slide. This is what it looks like in real life. You know, what you see here is basically that the idea here is that the head of the pancreas sits in the middle of a numerous blood vessels, and that's what makes this such a difficult procedure to perform. Next slide. And once again, here's some additional anatomical considerations. Sometimes we reconstruct some of these blood vessels as part of these operations. Next slide. So this is an operation that has considerable complications. There's a 30 to 40% complication rate and a very high leak rate, specifically from the connection between the pancreas and the jejunum. And the operation carries a 2 to 5% mortality rate, which is not insignificant. In our center, those rates are on the lower end of that spectrum. And you know, the most important thing is, if you're considering a surgeon who's performing these procedures, it's important to consider somebody who performs high volume surgery. Next slide. So just to finish off, screening in pancreatic cancer is a new hot topic, and there are families where there are numerous patients with pancreatic cancer that present, and we have now identified several genes that are responsible for at least having a predisposition for pancreatic cancer. The current method of screening is a combination of MRI and endoscopic ultrasound. And if somebody has greater than 2 first-degree relatives with pancreatic cancer, then genetic screening is warranted. Additionally, if patients have other hereditary conditions such as BRCA1 or BRCA2, which is associated with breast cancer, Lynch syndrome or Pugh-Jaeger syndrome, pancreatic cancer screening is additionally considered. Generally, what that involves is a yearly or sometimes an MRI every 6 months and endoscopic ultrasound during the same period. Next slide. It's important to realize that the average risk individual has no warrant for screening, because the risk of pancreatic cancer overall in your lifetime is small, and there's, in a relative sense, very few cases, although when they do happen, they are quite deadly. And as I had mentioned, MRI is the standard therapy, standard screening modality. Next slide. Palliative care is a final topic. We do want to touch base on, you know, what do we do if you have a bile duct obstruction? And oftentimes, what happens is we place our endoscopic colleagues will place a metal stent. Very rarely, I will have to go in and surgically bypass that area if the blockage cannot be resolved. Sometimes the stomach gets blocked up by the tumor, and then in that case, we have to perform again a bypass surgery called the gastrojejunectomy. Next slide. Chronic pain is also an issue, and there are pain management techniques, including injecting some of the nerves in the area of the pancreas to help out with some of the pain, and also the pancreas itself. Sometimes when it's not functional, it can give people diarrhea, and we provide supplementation so that doesn't happen. And it also does make you clot, having blood clots more likely, and we oftentimes place these people on blood thinners. Next slide.
Okay.
And
Now we'll talk about chemotherapy, which is back to me. Thank you, Alec. So we'll kind of run through this very quickly. As we saw, most of the patients are presenting in a phase where we can't offer them treatment with surgery, and some of the patients need neoadjuvant treatment, so that's where chemotherapy comes in. I'll quickly kind of go through some of this. Next slide. These are some of the drugs that are used for chemotherapy purposes. Next slide. The FDA has approved these particular drugs for their use. Xeloda, 5-FU, Gemzar, irinotecan, and Abraxane. Not a lot, but there are some drugs that are being used that are not FDA approved yet, even though for a dozen years we've been using them. One example would be oxaliplatin. Next line. Okay, so chemotherapy can be used either before surgery, that's called neoadjuvant, as stated, to try to shrink the tumor down to make a borderline resectable patient resectable. It can be done after the surgical resection, that's called adjuvant treatment. So tumor has been completely removed, and we think that by treating a patient with chemotherapy afterwards, we can increase their survival, because not all patients that are resected are cured. In fact, only less than half. For locally advanced non-resectable, those are the tumors that have not yet spread beyond the area of the pancreas, but are not able to be operated on. We'll sometimes use what's called definitive chemotherapy with radiation therapy. And advanced disease is really palliative, designed to improve the person's quality of life. Next slide. Next slide. So looking at the, I think we're one too far. Adjuvant therapy. Adjuvant therapy, looking at some of the trials. First trial was looking at a drug called Gemzar compared to doing nothing at all, and they found that a 5-year survival improved. These are patients who were resected with the idea that they were cured, hopefully by surgery. That the 5-year survival doubled from 10% of patients getting nothing to 21% of the patients who got one type of chemotherapy. The next one is looking at 2 drugs, adding Xeloda, which is a pill, to gemcitabine, and the improvement also was 50% over Gemzar alone. And finally, using 3 or 4 drugs, which is FOLFIRINOX, 3 drugs which are chemotherapy, 1 versus Gemzar, looking at the improved survival, median survival also improved. That's not to say that all patients live 54 months, that they haven't hit that 50% yet. So that's trial that's still out. Next line. So we saw that the adjuvant chemotherapy can improve the survival in patients, the small group of patients that can be resected. So giving adjuvant chemotherapy is now a standard thing to do in patients who are able to tolerate it. How about radiation therapy? Going back to 1969, where we looked at radiation therapy alone versus radiation therapy in 5-FU, and we found that there was a 4-month survival advantage. There's not a lot of studies that look at radiation therapy in a prospective randomized trial, but there are some as this that showed some advantage. We haven't gotten a lot better since that time to show that there's a huge survival. But we do radiation therapy because it seems to delay tumor recurrence and palliate and prevent that recurrence from causing a lot of symptoms. Next slide. Okay, so now we're into patients who have metastatic disease. And so their survival is what, 1 to 2% at 5 years. So we're looking to see is what added benefit is given by the chemotherapy. And as you can see that in each of these cases, the different treatments add months of survival. The best being FOLFIRINOX, which seems to add about 11 months of survival. So we're not getting huge impact, but we are seeing in the patients who are getting the chemotherapy, there's a delay in them getting it, and we feel an improved quality of life. So that's called palliation. Next slide. So palliation is not just survival. That means pain control, with or without chemotherapy, but pain control, relief of obstruction, or prevention of obstruction, stimulate the appetite, dealing with chronic nausea, physical therapy when appropriate, emotional support, spiritual support. And when chemotherapy is no longer being effective, helping people through that portion of their life we engaged the hospice program. Next line. Summary of treatment here that we would both agree is that resection of the tumor is the only chance for a cure. And so that's why surgery is very important if we can have that chance. Resectable patients should undergo surgery without delay, and then we do adjuvant therapy afterwards. The borderline resectable patients may benefit from chemotherapy beforehand and then surgery. As Alex mentioned, that we may be doing neoadjuvant in the future, but at least that's not quite off study the thing we would do. Unresectable patients may benefit from chemotherapy radiation. They palliate their disease, and metastatic disease may benefit from chemotherapy as well. Next slide. What do we do beyond chemotherapy? Well, we have these things: targeted therapy, immunotherapy, PARP inhibitors, and other things. Next slide. Targeted therapy. Next slide. So there's various things on the surface of the cells. There's and inside the cells. They're called drivers of growth, and sometimes they can mutate, and we can take advantage of that. And it's called targeted therapy. An example is Tarceva, which was approved in cancer of the pancreas, but we rarely use it anymore because it's not terribly good. The ALK, next slide, is another one that's used in cancer of the lung. It is very rare in pancreatic cancer. NTRK fusion, also very rare, less than 1% of patients. BRCA mutation, where we could use a drug called PARP inhibitors. Next slide. But here's a problem with targets in pancreatic cancer. There are some, such as EGFR, which are high, but the drugs don't work very well. And then there's some that the drugs work, but the results are very low. So right now, it's pretty rare to find a patient with pancreatic cancer in which we can use targeted therapy in which it works, as opposed to lung cancer, where it's up to 33% who have an available target and pretty good response rate. The results for pancreatic cancer are not very good. Next slide. Immunotherapy is another treatment we use, or looking for more patients as we're not happy with the targeted therapy results, or there's none available. We find that, again, PDL1, which is looked at in lung cancer and in 16 other cancer types, and there's 6 different types of these drugs, and they're advertised all the time. And we find that 50% of pancreatic cancers have this, which is even higher than most of the others. However, it doesn't work. Next slide. We do have something called microcytokine instability that occurs in 1 to 2% compared to colon cancer. It works quite well in pancreatic in both cases, but again, rare to be able to find a patient. So what do we do? Well, we do something like we call foundation medicine. We're looking at more and more and more mutations and drivers of malignancy, and we have more testing that we can do. Currently only 2 for pancreatic cancer that are found, but again, pretty rare, less than 1%. NTRK is less than 0.5%, TMP 1 to 2%. We find a patient that we can help. Next slide. And when we go to the next slide. And the point of this is, I think that if you say, oh, you have 1 or 2% of one and 1 or 2% of another, if you get enough, 50 different things you can look for, maybe you're going to get up to a significant portion. That's what seemed to happen in lung, so we're not ready to give up in looking for targeted therapy and immunotherapy. Next slide. Okay, the future, we want to see if we can prevent the cancer by doing risk reduction, stop smoking, maintain adequate weight, not overdoing alcohol, look at the familial reasons why, earlier diagnosis, be able to screen the high-risk patients, find it in an earlier stage, and better imaging, and research. I think that's last slide.
Yes.
Question and answer. I kind of flew through that, but I wanted to at least touch on it. Yeah, it's a tough disease to talk about because we are making very slow inroads, but I think given time and looking at enough ways of treating it, we'll see some improvements in the future. Question and answer, I guess, if we have a little time.
Yes. Thank you, Dr. Iskovich and Dr. Schuman. We do already have some questions in the chat box, so I'll give you those questions. And if people have more questions, please feel free to type them in. So the first question we have is, why isn't there more advocacy for annual or semi-annual endoscopies, such as they do for colonoscopies and mammograms?
Want to take that, Alex?
Yeah, so the real question in terms of screening is, what is your individual risk? So screening in pancreatic cancer is something that's really evolved in the last 5 to 7 years. And because pancreatic cancer is a much rarer disease than colon cancer or breast cancer, for example, the resources that are required in order to be able to find these few cases are considerable. So just doing MRIs, let's say, on everybody yearly is not a feasible thing to do. So we have to predict things that are risk factors for the pancreatic cancer, such that we would be able to find the right people and then screen those people. And what we've been able to find is these series of genes, as well as familial risk. And when you have family risk, specifically more than 2 people in a family, that's when you really start to look at screening, and that's when these screening modalities can identify cases very early. I can tell you, for example, I have a family that I've treated where there are 7 brothers and sisters, all with pancreatic cancer, and that's clearly a familial genetic situation. That's the type of people that we're looking at screening now.
So also, if you say, again, 3% of cancer, so it's not a high degree of cancer. There's a lot of people dying from it, but not being diagnosed with it compared with breast. Second of all, the imaging isn't as good with breast cancer imaging. You're really able to find very small early tumors, and that's still, even if you're imaging patients, they're still not getting the best quality imaging with the pancreatic cancer, and still catching these things late. And so I think the blood test like PSA hasn't been as reliable either. So we just don't have the tools as well. And in addition, the screening, if you're talking about CAT scans on a frequent basis with patients, is an expensive way of screening. So I think a lot of reasons why it's not being done is maybe there'll be a better modality in the future for screening. Another question?
Thank you, doctors. Next question is a fatty pancreas a major indicator of potentially getting pancreatic cancer?
Again, for you, Alex.
Yeah, generally not. The real risk factors for pancreatic cancer are family history, smoking. Those are the real things. The characteristics in terms of imaging specifically tend to be more diseases such as cystic disease of the pancreas. So if somebody has cysts in the pancreas, that's very different than, let's say, having a fatty pancreas. So fatty pancreas is generally does not really convey any risk for pancreatic cancer.
Thank you. The third question we have is, at what age do you recommend screening with an MRI, etc., if 2 relatives had pancreatic cancer?
So it really depends on the individual case. Generally speaking, the screening can be anywhere from 40 to 50, but it really depends on how old the people were who had the pancreatic cancer in the family. You really want to screen about 10 years before the youngest person who had gotten the pancreatic cancer.
Does anybody have, thank you very much. Does anybody have further questions? Otherwise, I'll chip in with one more of my own, which may sound somewhat ignorant, but I noticed that you said that increased diabetes was a marker. Are type 2 diabetics in particular considered more at risk for pancreatic cancer?
So generally speaking, not. However, what happens is that if a tumor takes over the pancreas, those the islet cells, which Dr. Schuman had mentioned, they get invaded with the tumor, and they are the ones that make insulin. So if you have less insulin making cells, as a result of that, you tend to have new onset of diabetes. So one of the things that can sometimes be tricky is that new onset diabetes in the age of, let's say, 60 or 65 should provoke the suspicion that there could be something going on with the pancreas in addition to the routine things that can cause diabetes.
Okay. Thank you so much, doctors. Thank you, Dr. Iskovich and Dr. Schuman, for taking the time to present on this topic and to answer our questions. Again, this has been recorded and will be available on Plainfield Public Library's YouTube page. The next topic in this series is colorectal cancer, which will be at noon on December 3rd, 2020. Thank you, everyone, for joining us for today's talk. Take care and stay safe.
Thank you.
Thank you.
All right. This concludes our Lunch and Learn with the Doctors on Pancreatic Cancer from the Regional Cancer Care Associates and Plainfield Public Library. Thank you again to our presenters, Dr. Alexander Iskovich and Dr. Richard Schuman, and to Regional Cancer Care Associates who facilitated their presentation here today. How to find us. Regional Cancer Care Associates of Central Jersey can be reached at 888-824-8312 or at their website at www.centraljerseyrcca.com. Comprehensive Surgical Associates PA can be reached at 732-346-5400 or at their website www.hackensack-meridian-health.org/locations/general-surgery-edison-comprehensive-surgical associates. Plainfield Public Library can be reached at 908-757-1111 or at our website www.plainfieldlibrary.info.